In veterinary practice, examining the oral cavity at every visit is a standard part of a full examination. This is to enable preventive measures to be taken, but also to identify conditions which will become relevant later. If the findings indicate that tooth extraction must be considered, this should be confirmed by a more detailed examination. Besides taking a detailed medical history, clinical examination with an oral mirror, the use of imaging techniques and other specific examinations, such as endoscopy, are all part of the standard repertoire for a comprehensive examination of the oral cavity. Of all these techniques, visual examination and palpation of the whole mouth are certainly the most important for an optimal final diagnosis. Depending on the findings, tooth extraction may be indicated for various reasons. Regardless of whether it is a molar or an incisor, the medical conditions can basically be divided into various main groups. One of the most important is certainly tooth fractures, but also periodontal or endodontic diseases and multifactorial problems. Once a diagnosis is made, we have to use all the means at our disposal to supplement and corroborate our clinical examination. As far as the incisors are concerned, we don't need many aids to do this, but more detailed diagnostics on the cheek teeth do require rather more equipment. Because of the anatomical conditions I have already described, I'd like to begin with a good, bright headlamp. Today, these are fitted with LEDs. This has the decisive advantage that they are lighter in weight, do not get hot, last longer, and also that you can regulate the brightness. Various models satisfy the different needs of their users. Personally, I use this model. The next item to mention is the oral mirror, which is part of the standard equipment. The oral mirror should have a diameter of approximately 50 millimeters. Since it is very common for the surface of the mirror to get damaged or scratched, it is an advantage if the mirror head can be replaced, as is possible with this model. This ensures that we are always able to work to the high standard necessary. We will be using the oral mirror a lot more in the course of this recording. Probes of various types are also part of the standard equipment. Here we would like to introduce the periodontal probe with exchangeable tips. The handle is 40 centimeters long, which enables even the most distal parts of the oral cavity to be reached. This probe was developed here in collaboration with the Erbrich company. The long right-angled probe is for examination in the rostral area and is suitable for very deep pockets. For examination at the back of the mouth, space restraints and the anatomy mean that the double-angled probe is more suitable. Here you can see what is called the Vienna scale with markings at 2 mm intervals. The measuring area of this probe is 40 mm long. It is made of hardened steel and is designed to withstand more robust use. In order to check whether a pulp cavity is open, in other words, whether there are defects in the secondary dentine, we can use what is known as a pulp hook. Like the probe previously mentioned, this can also be screwed into the 40 cm long handle. In everyday practice and with real patients, we need a stable mouth speculum to perform tooth extraction. For the demonstration, we have used a Günther mouth speculum, since this makes it easier to film the procedure from the side. Examination of the oral cavity starts with the general overview. Then the individual arches and finally the individual teeth are examined in more detail. It is important to establish whether the number of teeth per arch is correct. That is to say that there should be 6 cheek teeth per arch. If there are 7 or more, this is known as polyodontia. But evaluation is not done purely visually. The individual teeth are also palpated. Particularly in the case of old horses, it is possible to feel loose teeth in advance. To examine the pulp positions, we use the pulp probe to palpate the individual positions. We start from the rostral or buccal aspect with position 1. Caudally or distally of this is pulp position 2. Then we skip the infundibula and move rostrally to pulp position 3, and palatal, caudal of this is position 4. Finally, we arrive at the most palatal position 5. You can see that the probe glances off the secondary dentine. This is a normal finding. In contrast, we see on the tooth rostral of this number 7 that position 2 and 4 are closed, whilst in position 1 the probe is clearly hooking in. I can also insert the probe into position 3 and hook it in. And likewise in position 5. These 3 pulp positions are patent. As this is a number 6 tooth, we can inspect pulp position 6, that is the most mesial pulp position. And we can see that here too there is an opening of the pulp. Here we can see on tooth 109, the first maxillary molar, that there is a piece of food caught in the rostral infundibulum of this tooth. The reason for this is that too little tooth cementum has formed in this infundibulum. So what we are dealing with here is cemental hypoplasia, which has not yet progressed to infundibular caries. Now we use the probe to try and remove the trapped food from the infundibulum. It is generally the case that, particularly in young horses, the infundibula are far deeper than the length of the probe. And so cleaning infundibula that have filled up with food is a very time-consuming task. Now that we have inspected the occlusal surfaces, it is essential that we also have a look at the buccal and palatal surfaces of the teeth. Here, we will be able to see if there are any slab fractures. In this case, there are none to be seen. These slab fractures are sometimes found in combination with pulp involvement. In the lower jaw, we also examine the lingual surface and the buccal outer surfaces. We also look out for trapped food or gingival pockets. Here, I would like to draw attention on an interproximal space in which we can still see feed debris. Most of the debris has already been removed, but in this area we can see that the gingiva is already receding. With this type of diastema, it is worth checking with a probe. We take a periodontal probe and clean the interproximal space of food, then advance the periodontal probe carefully into the interproximal space without artificially creating a deeper cavity than is there already. In the course of the visual examination, we notice what is probably the most common finding when examining the oral cavity of a horse, namely sharp edges of the teeth. These can, as in this case, cause very deep injuries, particularly in the caudal region of the oral mucosa of the cheek. When we now start the tooth extraction, the first instrument we need is the gingival separator. This is this instrument. Unlike the root elevator, this instrument has a straight and sharp blade, and there are 2 designs available. One for the buccal or palatal side, as shown here in the image, the other with a 90-degree angle for the mesial or distal side of the tooth. The next instrument we need is what is known as a spreader. This is an instrument with blades shaped like an axe, and it is used to expand the interproximal space by closing the jaws of the instrument. This instrument is probably the one most associated with tooth extraction. It is the extraction forceps, which is used first to loosen the tooth and then for extraction. This model is distinctive for the different ribbing along the jaws, both crosswise and lengthwise. The jaws are movable, so they adjust precisely to fit the tooth, and there is a locking system on the handle end of the forceps. In this forceps model, the locking system is built in so that the forceps can be reliably and securely locked without having to continuously exert manual force. In order to lever the tooth out of the socket, we need what is known as a hypomochlion or fulcrum. Ideally, this has movable jaws with different heights. We will see this instrument in action very soon. For the extraction of incisors or wolf teeth, we need a root elevator. These are long, straight instruments with ribbing at the tip. We find this principle implemented in a similar form in the case of root elevators for molar extraction. Here too, we can see there is a ribbing. To facilitate the best possible examination with the oral mirror, we angle the light from the headlamp directly onto the mirror so that we can examine the occlusal surfaces of the lower and upper cheek teeth, and later the side surfaces too, under ideal conditions. In order to detach the gingiva on the buccal side, we use the separator with a longitudinal blade. Now we try to insert the elevator between the tooth and the gums, making sure to keep it close up against the tooth all the time. The same goes for the alveolus, and so we achieve an initial loosening of the periodontium. Gradually, the elevator is inserted further and further between the tooth and the socket, so as to loosen the tooth as far as possible with this action. Now we carry out the same procedure on the lingual side. The next step in the tooth extraction is what is known as spreading the tooth. This serves to create space for the tooth so that it can be moved within the socket. We now want to extract this number 10. This is the second molar. With this tooth, it is important that we start the spreading process in the interproximal space towards the middle of the arc. That is the space between it and the neighboring tooth towards the front of the mouth. Otherwise, we would loosen the last molar too much. At the back of the mouth, it is particularly difficult to position the spreader correctly because it has to be located directly in the interproximal space. Sometimes it is easier to deliberately not position the spreader correctly, but instead to press it lightly against the tooth and then rotate it into the interproximal space where it can engage. You can feel this through the handles. Whether the spreader is correctly positioned can be checked now with the lamp, with the mirror or the endoscope. Then we can start applying pressure. Closing the spreader takes time and patience, and you have to give the tooth time to move back. At intervals, the instrument is closed further and further. This moves the tooth being extracted away from the neighboring tooth, and the interproximal space becomes increasingly large. Next, the interproximal space to the last tooth is widened. Here too, it is important to position the spreader correctly and deep enough on the tooth before gradually closing the jaws of the instrument. We can see how the closing of the jaws pushes the teeth apart slightly. If we have a dental fracture, as in this case, it is often useful to grip the tooth as far down the crown as possible with special forceps like this one. The correct positioning of the forceps is checked first by moving the tooth slightly in its socket before the forceps is fully closed. Any tooth can be moved a few tenths of a millimeter if the forceps is positioned correctly, as we can see in this image. If the position is correct, the forceps can be fixed tightly to the tooth. Now we position the extraction forceps on the tooth that is to be extracted. For this, we try to grasp as much as possible of the crown, but only of this tooth. That's why we check the positioning of the forceps carefully by trying to move the tooth a little. If the forceps is positioned correctly, any tooth can be turned a few millimeters or at least a few tenths of a millimeter, particularly after loosening. This can be observed. If this is the case, as here, the forceps can be secured firmly to the tooth. The forceps is fixed by engaging the threaded rod and tightening the tensioning screw. Now the tooth is gradually loosened using horizontal movements, slowly at first. The rotation movement causes progressive tearing of the periodontal fibers, and the tooth becomes gradually more mobile. This loosening motion can be intensified by loosening movements along the longitudinal axis of the tooth. Repeated spreading during the extraction also helps to loosen the tooth. Here we can see that the teeth and their supporting structures are very dynamic structures, and at this stage the tooth can already be moved clearly with the help of the spreader. When the tooth can be moved freely in the longitudinal and lateral axis, you can start to think about extracting it. For this, we need the hypomochleon, which we position as close as possible under the lock of the forceps, and now we can gradually lift the tooth out of its socket, using pressure on the ends of the forceps. If, As in this case, we find that the root has unfortunately broken off. We must first loosen the root fragment using a root elevator and then retrieve it. For this, we use the appropriate root elevator from the set of 4 instruments. For tooth extractions in the upper jaw, particularly in the initial stages, it is important to note the course of the greater palatine artery, which is located in its sulcus in this area. For instance, when preparing the gingiva, care must be taken to keep the instrument right up against the tooth and not slide off the tooth at the bone and damage the blood vessel in this area. At the beginning of this movie, it has been mentioned that the equine oral mirror is one of the most fundamental tools for diagnosis in the equine oral cavity. Now I want to draw your attention on a further development from the Erbrich company. This mirror excels by its light weight and some extra benefits like an easily exchangeable mirror glass. Equine dentistry has improved dramatically in the past 20 years. Today, even elaborate procedures like the extraction of cheek teeth in standing sedated animals are possible. This was considered impossible 20 years earlier. Equine dentistry had to catch up with developments made in human dentistry half a century earlier. The main reasons are the significantly different equine anatomy and physiology, which differ significantly from humans, dogs or cats. The Hippo-Dent equine teeth continue to erupt from the jaws, which is enabled by continuous changes of the periodontal ligament. This, the sheer size of equine teeth and the fundamentally different anatomy are the main differences between human and equine dentistry. Consequently, the equine dentist faces significantly different problems in the oral cavity and needs different tools and techniques which can be helpful to overcome these difficulties. Although the extraction of a cheek tooth is still a challenge for the equine practitioner, it has become a task that can be managed successfully. In a final step, the alveolus was closed with a plug made of disinfectant gauze. This is already a very essential part of the postoperative aftercare. During the regular examinations in the course of this plug changes, complications or problems like infections, inflammations or the formation of sequestra might be encountered. In such a way, the veterinarian can react in a timely fashion to those complications in order to bring each case to a successful end.